All right, well, today we're going to be talking about hypertrophy. So first, let's start off with atrial hypertrophy. Okay, well, when you're dealing with atrial hypertrophy, you want to look at what the P wave is like. So we have left atrial hypertrophy, and we have right atrial hypertrophy. And another name for left atrial hypertrophy is P mitrale, and right atrial hypertrophy is P pulmonale. And there's two things that we're really interested in looking at in order to diagnose atrial hypertrophy. One is the configuration of the P waves, and the other thing is the vector of the P wave. What lead are the P waves seen in? Okay, so first in terms of configuration, what does the P wave of left atrial hypertrophy look like? Right, it's broad and notched. In contrast, P pulmonale, the P wave, is tall and peaked. Okay, well, when we're talking about broad, what do we mean by broad? How long does it have to be in terms of seconds? Right, greater than 0.11 seconds. Significant prolongation of the P wave. In terms of peaked, how many millimeters tall does it have to be peaked? 3 millimeters. 3 millimeters in height in order to be peaked. Okay, so that's configuration. Now let's talk about vector. Now what is the vector of the left atrial P wave as contrasted to the right atrial P wave? Well, the left atrial vector tends to go more leftward and posterior, whereas the right atrial P wave tends to go more vertically and anterior. Vertically, straight down, and anterior. Okay, so what leads shall we look at? Okay, in terms of leftward, what are the leads which record leftward deflections? They are 1, 2, AVL, and V4 through V6. So in left atrial hypertrophy, broad notch P waves, we'll see them best in these leads, 1, 2 AVL, and V4 through V6. Okay, in P pulmonale, we said the vector is directed vertically or inferiorly. So what are the inferior leads? It's leads 2, 3, and AVF. Okay, 2, 3, AVF. Okay, so that's one is going horizontal, the other is going straight down, inferiorly. Now in terms of antero-posterior direction, what is the lead that you want to look at to tell you whether forces are coming anterior or posterior? Right, you look at lead V1. Okay, and we said the P wave in left atrial enlargement is going posteriorly, so in V1 we'll see a negative P wave, right? In right atrial hypertrophy, we said it's coming anterior, so in V1 we'll see a positive. We'll see a positive P wave, it's usually peaked. Okay, now let's take a look at biatrial enlargement. Biatrial enlargement can be both peaked and broad in its configuration. You best see biatrial enlargement in lead V1, where you get a biphasic complex, tall positive and broad negative. It's a biphasic complex. But the important thing is not that it's just biphasic. It has to be biphasic and tall and broad, right? And practically everybody that you take an electrocardiogram on, or many persons, it's going to be biphasic. That doesn't mean they have biatrial enlargement. It has to be both tall and of long duration. Okay, now on many patients we see some conflicting data. For instance, we see a broad notch P wave, but we're surprised because it's best seen in leads 2, 3, and AVF. Or another thing that you see, for instance, is you see peak P waves, but it's best seen in and 1 in AVL. So there seems to be a discrepancy. So what do you do in that situation? Well, the thing to point out is that in terms of weighting, configuration probably has a stronger weighting factor in the diagnosis. So I'd pay more attention to configuration than the vector or the axis in terms of establishing a diagnosis or in terms of impression of what the patient has. If you see agreement, you're very confident of your diagnosis. If you see a discrepancy, you're not as confident. It's a matter of degree in terms of how sure you are of the diagnosis, and you just have to use your judgment. The more you see, the more confident you generally are of a diagnosis of atrial hypertrophy. All right, so that's atrial hypertrophy. Any question about that? Okay, now next let's go over ventricular hypertrophy. And the first thing we'll talk about is LVH. Okay, so what are the criteria for left ventricular hypertrophy? Okay, the first criteria we want to think about are voltage criteria, right? We should go by this outline. Usually when I ask people what are the criteria for LVH, all of a sudden they start listing me some numbers, voltage criteria, things like that. But the best thing to keep in mind is this outline that we're going to make. Voltage criteria. So another criteria then would be axis. The third would be intrinsicoid deflection or ventricular activation time. And the fourth one would be ST T-wave changes. Okay, so this is the basic outline that we're going to want to follow. And in part of our routine for reading electrocardiograms, we're going to ask ourselves, does this patient have ventricular hypertrophy? And when we're asking that question, we should go right down this list. Voltage, axis, intrinsicoid, ST T-wave changes. Well, let's go on now and say, what are some of the voltage criteria for LVH? Okay, there's, if you look in the books, you can probably find at least a dozen criteria. I think it's good to keep a few in mind. And here are some of my favorites. I think they're perhaps not too difficult to remember. Okay, if you take the S in V1 or V2, whichever is bigger, plus the R in V5 or V6, whichever is larger, and if the sum of those two is greater than 35 millimeters, that's one of the voltage criteria for LVH. So we have in V1 we see deep S's, and V6 we see tall R's. You add the negative deflection to the positive deflection. And should be greater than 35 in order to see left ventricular hypertrophy. All right, now you can also say you take the S in V1 or V2, and you say, or the R. This is plus, right? We're adding it together here. Now we take either one by itself, this deep S or this tall R, either one by itself greater than 25. Some people say 26, some people say 24. I think 25 is certainly adequate. It's a good number, and it's easier to remember. Okay, then there's a few other numbers that are nice to remember. The R in AVL, let's look at AVL, and if the R wave in AVL is greater than 11, R wave in AVL greater than 11. Okay, and we have the R in lead 1 plus the S in lead 3. You know that lead 1 normally looks like that, and lead 3 in LVH looks like this. So the R in 1 plus the S in 3, again, greater than 25. Okay, so those are a few numbers that are worthwhile carrying around with you and remembering in terms of voltage criteria for LVH. So these fall under voltage. Okay, now what about axis? What type of an axis do you need for left ventricular hypertrophy? Right. You need a left axis deviation. And as you recall, a left axis deviation goes from minus 30 to minus 90. In other words, you're in this quadrant. Okay, that would be a left axis deviation. Okay, that's another good criteria for left ventricular hypertrophy. Intrinsicoid deflection. Now, the intrinsicoid deflection is one of the poorer criteria, but it's listed in almost all of the books. From what I've seen, it seems to be positive, I'd say, in patients with hypertrophy, maybe 30% of the time, something like that. It's not very frequently positive, but it's something worth looking at. Okay, so in terms of left ventricular hypertrophy, which lead do you look at to see a prolonged intrinsicoid deflection? You look at V6, and V6 normally, to expand a little bit, looks like that. So the intrinsicoid deflection, or the ventricular activation time, as it's sometimes called, goes from the onset of the QRS to the peak. The onset of the peak, that duration of time is the intrinsicoid deflection, or the ventricular activation time. And it supposedly is the time that it takes from the onset of activation until the vector loop comes out and sweeps by lead V6. And with thicker muscle, supposedly it takes longer. Probably with thicker muscle, there's some fibrosis and some terminal conduction disturbance, and it takes a little bit longer to get out to V6. And that's thought to be the probable reason for the prolonged ventricular activation time that you occasionally see with LVH. Okay, so this duration then should be 0.05 seconds or greater in order to make one of these criteria for LVH, 0.05 seconds or greater. Okay, now then these three are the basic criteria for LVH. This is also important, but let me just consider that separately. But before I do that, let me just go back a little bit and talk about some exceptions to these rules. Now, voltage criteria for hypertrophy. Voltage criteria are unreliable in young patients. In other words, patients under the age of 35. Under the age of 35, voltage criteria, you frequently see voltage criteria, the patient does not have LVH. Also seen in thin-chested people that may even be older than that. So these are things that you have to keep in mind. Now, in the younger patient, somebody, let's say 20, 25, or even teenage, axis actually is a better criteria for LVH than is voltage. And as a matter of fact, if in a young person, if you see an axis that becomes more left than 0 degrees, you can probably, this is somewhat suggestive of left ventricular hypertrophy. Okay, so axis in young person, that's an important point to keep in mind. Axis in young persons can be more reliable than voltage. Okay, in elderly people, however, it's just the reverse. Voltage criteria are more reliable than axis. As you may have noticed, in many elderly patients, they have a left axis deviation without having hypertrophy. So therefore, voltage criteria seems to apply more to the older person. It seems to be more valid, or a more reliable index of hypertrophy than axis. And in the young individual, it's the reverse. Okay, now let's talk about these STT wave changes. These are a sign of severity in left ventricular hypertrophy. If you see LVH in association with STT wave changes, this patient probably has pretty severe left ventricular hypertrophy, and it's getting to the myocardium. It's doing nasty things to the heart muscle. You're getting relative ischemia. Now, it's also said that these STT wave changes have some prognostic significance. And it's said that patients with hypertrophy in association with STT wave changes have a prognosis of under 5 years, probably in the average. It's just probably an average value. Okay, now these changes in left ventricular hypertrophy, as you might expect, should be seen over the left ventricular leads. And what are the left ventricular leads? That's leads 1, these are left ventricular leads 1, AVL, and V4 through V6. So this is the leads where you'd expect to see these STT wave changes. And they look like this. It might look like this. or they might look like, it's another common appearance that they look like that. This is the asymmetrical, what they call the asymmetrical T wave, down slow, up fast, and this is just ST segment depression, which looks like ischemia, as we've previously described it. Okay, so these are the types of ST wave changes. Now, some people, when they see this in association with left ventricular hypertrophy, like to call this strain pattern. This is what people call strain pattern. There are a lot of people that don't like that term. It's hard to define, exactly what that means, but I would think that strain means relative ischemia. Again, this pattern by itself, without any of the other signs of hypertrophy, does not really relate to hypertrophy. So you have to see other criteria for hypertrophy and then put this on top of it in order to establish its significance in ventricular hypertrophy. Okay, I prefer to call, when you see this combination, I prefer to call it left ventricular hypertrophy and ischemia. For instance, that patient may have left ventricular hypertrophy and may have coronary disease as well, may have the combination. So that these changes really are not due alone to left ventricular hypertrophy, but may be due to vessel disease as well. So therefore, I think probably a more objective term to apply to this would be left ventricular hypertrophy and ischemia, but just to point out that this is what people are talking about when they talk about strain pattern. Okay, are there any questions then about left ventricular hypertrophy? Okay, well, let's move on then and talk about right ventricular hypertrophy. Okay, RVH. In RVH, right ventricular hypertrophy, we can use exactly the same guideline: voltage, axis, intrinsicoid, ST wave changes. Okay, so going back to our voltage criteria again, let's list a few of those. These are really very easy. They're easier to remember than LVH. And it's, again, as with LVH, it's worthwhile keeping a few of these numbers in your mind. Now, the leads that you look at are V1 and V6. And in V1, what you see is tall R waves, right? And the tall R, this R wave gets to be larger than the S wave. So that's one of the criteria right there. The R-S ratio gets to be greater than 1. That just means that the R wave is taller than the S wave. Now, if you look at V6, you see just the reverse. The S wave gets to be deeper than the R wave. So we say R-S ratio is less than 1. Here we say it's greater than 1, here it's less than 1. All that means, again, is that the S wave is bigger than the R wave. Okay, so those are two criteria then. The R greater than the S in V1 and the S greater than the R in V6. That's two criteria. Now we can apply some numbers to this. Let's just attach some numbers here. If we add the height of this R wave plus the depth of this S wave, so we say the R in V1 plus the S in V6 are greater than 10.5. If the sum of those are greater than 10.5, that's a numerical criteria that you can use. If you take either one, the R in V1 or the S in V6, if either one of those by itself is greater than 7, if either one is greater than 7, if this R wave is taller than 7, if this S wave is deeper than 7, either one, that's another criteria. That's another number that you can use. Okay, so those are 4 voltage criteria. As I said, there's more that can be listed, but I think that at this point that's probably enough to list. Okay, then axis. What kind of an axis do you see with right ventricular hypertrophy? Right, you get a right axis deviation. So your axis then falls into this quadrant, right axis deviation. Okay? Okay, so that covers voltage, axis. Now, intrinsicoid deflection. In left ventricular hypertrophy, we looked for the intrinsicoid deflection in the left ventricular lead, which was V6. In right ventricular hypertrophy, you want to look at a right ventricular lead. So what's a good right ventricular lead that we use? It's V1, okay? So we look at the intrinsicoid deflection in lead V1. and V1 to expanded normally looks something like that. And the intrinsic coil deflection, again, goes from the onset of the QRS to the peak of the R wave. So this would be the intrinsic coil deflection. And this should be 0.04 seconds or greater for RVH to meet the criteria for RVH. Okay, so that's the intrinsic coil deflection. Now the STT wave changes in right ventricular hypertrophy don't have the same prognostic significance that those do in left ventricular hypertrophy, but they generally are a pretty rough index of the load upon the right ventricle. If there's a pretty high pressure load in the right ventricle, you'll see STT wave abnormalities, whereas with milder changes, you might not see them. So it's a rough, very rough index of severity. Okay, so then this then covers some of the criteria for RVH. Let me just draw this for an example here. This is V1 with a tall R, V2, V3, let's say it looks like that. Now, our T waves, we said, should be upright in every lead, in the precordial leads here, except for V1. So it would be all right to have an inverted T wave in lead V1. Maybe not that deep, but an inverted T wave. But in right ventricular hypertrophy, what you'll see is inverted T waves in V2 and 3. So your changes are in the right precordial leads, V1 through V3. This is the location of your STT wave, as you might expect over the right ventricle. V1 through V3, T waves, inversions. Okay, is there anything else that I have to cover about RVH? Are there any questions then about RVH or ventricular hypertrophy in general, left ventricular hypertrophy or right ventricular hypertrophy? Okay, again, the important thing to keep in mind is this outline. If you keep this outline in mind, everything else will just fall into place then. So just remember, always, voltage, axis, intrinsic coil, STT wave changes, and then everything else will come from that. Okay, now everything that we've talked about so far in terms of ventricular hypertrophy has dealt with what they call pressure overload of the left ventricle. For instance, pressure overload of the ventricles. For instance, a pressure overload of the left ventricle, that might be hypertension, aortic stenosis. Right ventricular overload would be something like pulmonic stenosis, that type of situation. So those are pressure overloads. The heart seems to tolerate a pressure overload poorer than it does a volume overload, and you get somewhat different changes actually in electrocardiogram. So let's just talk very briefly about volume overload of the left ventricle, what they also call diastolic overload pattern. This is diastolic overload. Okay, it's important to consider that volume overload patterns are generally seen in patients, in young patients, and in patients, particularly patients who have congenital heart disease. In the adult group, we most frequently see changes of volume overload in patients with intracardiac shunts or congenital heart disease, even though they may have a very severe volume overload of the left ventricle. For instance, what might give you a volume overload of the left ventricle? Such things as aortic insufficiency, that certainly might impose a very severe volume overload. Also, mitral regurgitation might impose severe volume overload. These are acquired, and in these situations, the patterns of volume overload are not very frequently seen. It's, as I said, in patients with congenital heart disease that you usually see these changes. And the typical changes that you might see in left ventricular diastolic overload, for example, are you get a prominence of the septal Q, and let's say this is in lead V6 or V5 or V6, the lateral leads, the left ventricular leads, and you see some T wave peaking. You see a prominent septal Q and you see T wave peaking. Okay, so this might suggest then a volume overload of the left ventricle, somebody that has a patent ductus or some congenital problem. Okay, suppose you were to approach an electrocardiogram that looks like this, though, right? Certainly there's other things that will give you large cues in the lateral lead, such as what? Some things that you have to consider. Right, one would be lateral wall myocardial infarction, right? This might be an old lateral wall myocardial infarction. However, if you had a 15-year-old boy as a patient, that'd be fairly unlikely. What's another thing that might give you a large septal cue? Well, what's another thing that enlarges the septum? What causes septal enlargement? Right, outflow obstruction of the ventricle, of the left ventricle, for instance, something such as idiopathic hypertrophic subaortic stenosis. And this is what's seen in patients. This is one of the findings in patients with IHSS. They have a thick septum, so they wind up with a large septal cue. And it's seen in the lateral leads and occasionally in the inferior leads, 2, 3, and AVF. So when you see a pattern like this, you should think of generally three things. Diastolic overload of the left ventricle, lateral wall infarction is a possibility, and then the rare disease, which is idiopathic hypertrophic subaortic stenosis, IHSS. Okay, now right ventricular diastolic overload. What pattern? Suppose you had a patient with an atrial septal defect. That's a typical disease which produces right ventricular diastolic overload. What might his electrocardiogram show? It shows an incomplete right bundle branch block pattern, right? This is what you see in V1, incomplete right bundle branch block. In other words, the QRS duration is between 0.10 and 0.12. It's not a very specific sign at all. You can see incomplete right bundle branch block in many normal people, but if you use this in conjunction with physical examination, and so you listen over the pulmonic area and you hear a flow murmur and you can hear a thick splitting of the second sound, and you see this appearance, this is very strongly suggestive then of atrial septal defect. Okay, I should also point out that in patients that have volume overload, if this is persistent and continues for many years, the pattern will eventually change to looking like a pressure overload type pattern. In other words, you'll get the other criteria that we just talked about for pressure overload: voltage, axis, intrinsic weight, STT wave changes. So in congenitals, as they go on later and later in their disease, they may develop the signs of pressure overload on the electrocardiogram. Okay. Well, I don't want to belabor this point. This is not that commonly observed. It's not the usual bread and butter stuff that you see on the electrocardiogram, volume overloads. And the patterns and the criteria here, as you can see, are not very good and not very specific by any means. Well, that finishes our discussion then of left ventricular of the hypertrophies, atrial hypertrophy, ventricular hypertrophy, pressure overload type, and volume overload type. Now let's continue on at this point and discuss what the effects are of pulmonary disease on the electrocardiogram. Okay, and we can break this down into acute pulmonary disease, acute, this is pulmonary disease, and chronic. So first let's talk about the effects of acute pulmonary disease on the electrocardiogram. For instance, if you had a patient, typically pulmonary embolism, this is something that everyone considers. Pulmonary embolism, but certainly other situations might produce acute pulmonary changes on the EKG, such as pneumonia, pneumothorax, and a host of other things. So what are the types of things that you see in the electrocardiogram? Well, the most common thing that you see in most of the cases are the changes are really very non-specific. You see such things as a sinus tachycardia, sinus tachycardia, and you might see some irritability, atrial irritability, very nonspecific. And also you get nonspecific T-wave changes. Nonspecific T-wave changes. And these are seen, in most of the patients. I'd say probably 75% of the patients get these very, very nonspecific changes that are really not that helpful. But in a relatively small percentage of the patient, maybe 30% or so, you see the more specific changes. So we have, these are nonspecific, and these are more specific. You see the more specific changes. And what are these? Everyone has heard of some of these, and they expect to find them on every patient that has, for instance, an acute pulmonary embolism. But as I point out, these are not that commonly seen. Well, what are some of them? One is, someone mentioned, you might see a shift in the axis to the right. Shift in QRS axis to the right. So a rightward shift in the QRS axis. That's a good sign. Okay, and in looking at acute changes, it's really very helpful if you have a previous electrocardiogram to compare with. This is of tremendous, can be a tremendous help. Another thing that you might see is what? Another thing that you might see is incomplete or complete right bundle branch block, the development of right bundle branch block. Again, this is particularly important if the patient didn't have it before and then suddenly develops it along with symptoms. Okay, that's another good sign. A third thing might be some peaking of the P waves. This is not too reliable again, but something to look for. Peaking of P's, increase in the height of the P wave. A fourth thing we might see is what they call this S1 Q3 T3 pattern. S1 Q3 T3. You look in lead 1 and you see an S wave. You look in lead 3, you see a Q and a T, inverted T. So this would be your S in 1. This is lead 1. This is lead 3. So you see an S in lead 1, a Q in lead 3, and a T, an inverted T wave in lead 3. This is the S1 Q3 T3 pattern described with acute right ventricular overload, acute pulmonary problems. What else might you see? There are a couple of other things. I can think of one right now, and that is that you might see T-wave inversion over your right precordial leads. You do not get any signs. Unless the patient has had pre-existing right ventricular hypertrophy, you don't suddenly develop signs of right ventricular hypertrophy on the electrocardiogram. It takes hypertrophy quite a while to develop, and this is an acute situation. But you might see signs of right ventricular overload or ischemia, and these are manifested by T-wave inversions. T-wave inversions in the right precordial leads, in the right ventricular leads. T-wave inversions V1 through V3, and maybe even further out. And sometimes these are also seen in the inferior leads. Okay, well, these are then some of the criteria, or some of the things that you might look for in a patient that you're considering as having an acute pulmonary problem. There's one more, but unfortunately I just can't think of it at this point. Well, let's move on. And now consider the effect of chronic pulmonary disease in the electrocardiogram. Chronic lung disease, for instance, a patient that has severe emphysema, bronchitis for many years. What type of changes might we see in his electrocardiogram? This is something that we see practically every day here. So it's worthwhile, certainly worth our knowing what his electrocardiogram should look like. And one thing that we see is low voltage. So what do we mean by low voltage? How low does it have to be low? What leads do you look at? Well, you look at the frontal plane leads 1, 2, 3, AVR, LF, and the voltage to meet the criteria for low voltage should not be greater than 5 millimeters in any one of those leads. So this voltage should be less than 5 millimeters. Okay. Another criteria might be P pulmonale. Okay, peaking of the P waves. So this is a second criteria that we see, a second finding that we frequently see in patients with pulmonary disease. A third criteria might be, as I've mentioned earlier, this extreme right axis deviation, or marked right axis deviation. These patients frequently have axes that go straight up, or they may go up into this quadrant. Okay, this is sort of an unusual axis, and anytime you see a patient with an unusual axis, it's worthwhile going back to see if they have the other criteria for pulmonary disease. Okay, just because this is not present, however, that does not mean the patient does not have pulmonary disease. All understand that. It's just a helpful thing if it is present, but just because it isn't present doesn't exclude the diagnosis. Okay, a fourth criteria is what? Clockwise rotation, right. Clockwise rotation of the QRS in the horizontal plane. And you all record clockwise rotation is like, you look for the isoelectric lead, and the isoelectric lead in the V leads we normally set is around V3 to V4. But in clockwise rotation, if you recall this diagram here, the patient lying on his back in the bed. Here's your clock. Normally it should be up around here. Clockwise rotation has shifted in this direction here. So instead of your transition zone, your isoelectric lead occurring V3 to 4, it's shifted out to around V5 or V6. It's shifted around towards the right. So that would be clockwise rotation. What this EKG looks like very frequently is you look at V1, V2, V3, V4, V5, V6. In other words, there's very poor progression of the R wave as you go across the precordium. And you might even be thinking a little bit of, well, does he have an anterior infarction, right? You might also be thinking of right ventricular hypertrophy, right? Because this RS ratio is incorrect. The S wave is too deep. So you say, maybe right ventricular hypertrophy, but you look over at V1 and you don't see a tall R wave. Right? What this really reflects is what they call clockwise rotation. This transition zone has shifted way over to the right. So I think that clockwise rotation is one of the better things to look for when you're considering pulmonary disease. Certainly also low voltage is as well. As a matter of fact, all of them are good criteria, good things to look for in a patient. Okay, so this is then a review of some of the changes in the electrocardiogram that you might see in patients with acute and chronic lung disease.